أعزائي طلاب المرحلة الرابعة السلام عليكم ورحمة الله وبركاته. Today we will talk about anti-cancer drugs. But before starting with these drugs, it is important to mention some principles and some statistics about cancer. So it is not like around or less than a quarter of patients, like less than 25% of patients with cancers will be cured only by a surgery or local radiations, while around 75% of these patients have to take chemotherapy for cancer. Even if they are taking chemotherapy, like around 10% of these patients will be cured or get a prolonged remission, like long time without symptoms of cancers. While the majority of patients, like around 90% of those patients, are not getting these benefits. Only what they get a regression for a while of the disease, and may they die from complications or relapse of cancer. Also, in addition to all these, it is known in a time period around 5 years, 75% of patients with cancers will die either from cancer or either from the adverse effects or complications of chemotherapy. So it is now ranked in the second position after cardiovascular diseases. These are just some statistics about cancer and treatment of cancer with chemotherapy, just to know the importance of chemotherapy with cancer patients. Here we have two tables show the chemotherapies that we will talk about them in this series of lectures, but of course you don't have to remember everything in these tables. The first principle here, we have let's say the importance of cancer chemotherapy. So the major aim or goal from using the chemotherapy is just to cause lethal cytotoxic effect or induce apoptosis in cancer cells. So our aim to kill cancer cells either through a direct effect, cytotoxic effect, or by enhancing or activation apoptosis in these cells, so these cells will die. However, on this attack, let's say the site of action of the chemotherapies in general, we are targeting here DNA or against certain metabolites that are active or doing some roles in cell replication. So either DNA or other metabolites in cell replication processes. In ideal situation, chemotherapy should interfere only with the processes that are unique to malignant cells. So if we have certain molecular mechanisms inside the cells by using certain metabolites or certain processes in the DNA, so these chemotherapies should target these pathways. But this doesn't happen in the real world because most of anti-cancer drugs that are now available don't recognize between neoplastic cells, cancer cells, and the normal cells, which are rapidly dividing. And this leads in actual to the huge or serious side effects that are caused by the chemotherapies. Now there is a new approach in the treatment of cancer by using drugs that are targeting what it is called checkpoints, or blocking these checkpoints in our immune system in order to activate our immune system to attack cancer cells. However, even this direction has some concerns as side effects such as autoimmune toxicity, and maybe there is overactivation for the immune system, and this starts to attack other organs inside the body. So in both directions of the treatments, we have some benefits and some adverse effects or side effects. This figure here, it is very important just to summarize the site of locations of chemotherapy where they are acting in the process of cell growth. So here we can see like we are starting from the purine and pyrimidine synthesis, and these are building units for DNA, and then DNA transcripted into RNA, and this one synthesized proteins. So in the process of the conversion from the purine and pyrimidine to the ribonucleotides, we have certain drugs that are interfering with the purine synthesis. So they are inhibiting the purine synthesis and inhibit DNA formations. We have another class. In the first class, we have, as an example, 6-mercaptopurine. While we have another or other classes such as methotrexate, 5-FU, 5-FU or 5-fluorouracil, and these ones, both of them are inhibiting to the formation of deoxyribonucleotides. Then from that point, we have another class that is working on the cytarabine that are working on the formation of DNA from this step, deoxyribonucleotide. And here we have an example, cytarabine. So all these classes are working on inhibition DNA synthesis. While we have other drugs that are targeting the process between DNA transcripted to RNA, such as bleomycin, dactinomycin, and other alkylating agents. And everyone is interfering with a different site of action, such for this one, it prevents the DNA, by an oxidative process. We will talk about this in more details later in the lectures. But this figure just to show the most important site of locations for chemotherapies, and it is an important figure. Then we have to define our goals from the treatments, like what we have to do or what we want to do with those patients. In general, we have two major goals: either cure the disease or palliations, decrease the signs and symptoms, and maintain as much as we can the normal or near normal life existence. So as we said, our ultimate goal from the chemotherapy is a cure, if it is achievable. And this one can be got either by using surgery, radiation, or chemotherapy, or combination of all these in order to eradicate every neoplastic cells. However, if we cannot get this goal, so we have to modify our goals to become like control the disease, prevent cancer from enlarging and spreading, and improving the quality of life and extend the survival. These are what it is called, like it is not like complete cure, but it is better than the just palliation the disease, as we will see in more advanced stages. Here, like as we said, we can use different strategies, either surgery, radiation, or combination with chemotherapy, all of them in order to control or manage the disease and keep it as a controlled level. However, in more advanced stages, like when there is metastasis, like the disease now is spread around the body, and it presents in more than one organs. So here our goals of the treatment is not similar to what we saw in the first part, cure the disease. Here our goal is just palliation, alleviation the signs and symptoms, and avoiding life-threatening toxicities, either by the cancer by itself or by chemotherapies. This means like chemotherapy drug may be used to relieve symptoms caused by cancer and improve to a certain level the quality of life, but we don't see like as much increase in the survival. So just better quality of life for the same time, and the patients after that will die. So it is important just to modify our treatments, our, let's say, combinational therapy, as we will see in a minute, just in order to achieve our goals. So this figure here, just to show the how can we use different strategies in order to get our goals. So here it is just to understand the theory. Is not this figure is not required, it's not necessary. But here we can see, like, when we have a small mass of the cancers and is not detectable by physical examination, then the mass started to increase. Here we have, let's say, maybe 3 or 4 major routes, either by using surgery and the patient getting complete cure. But sometimes this is not attainable, so we have to use chemotherapies, and chemotherapies here are used in different combinations and for different intervals in order to get cure. Or either sometimes we can combine both surgery and chemotherapy, as we will see. However, some cases that are at the beginning, they are responsive to the treatment, but after a while, due to the resistance, which is a common problem with the cancer, we will see, like, there is no response, much response with the chemotherapy, so the patient is heading up to the death. And sometimes when there is metastasis, a patient dies in a shorter term. So here we have like different ways for treatments or getting our goals. It depends on the case, it depends, sorry, on the stage of cancer. So when we have to indicate chemotherapy for patients, here we have mainly four situations that we are using chemotherapy in them for cancer patients. The first one, when we are using chemotherapy, when we have metastasis and the disease now presence in more than one organ inside the body, so it is hard just to use surgery, because surgery here you cannot remove many parts from the body. So here it is, let's say, more logic to use chemotherapy for those patients, and this is similar to what we discussed in the advanced stages of cancer. Also, we have to use chemotherapy as supplemental treatment to attack micrometastasis following surgery or radiation. And here we are talking about combinational therapy between surgery, radiation, and chemotherapy. And this one is called adjuvant chemotherapy. Also, sometimes chemotherapy is used prior to the surgical procedures in order to decrease the size of cancer. So especially when there is no metastasis, and this one is called neoadjuvant chemotherapy. And finally, chemotherapy also is given for in a lower doses, low doses, but for long time in order to maintain the patient in a remission state. Like remission state, better quality of life, lowest symptoms, and lowest toxicity from the treatments, just to maintain this remission state as much as we can. Then we have tumor susceptibility and the growth cycle. Here we have a term, it is called a growth fraction of the tumor. And this one means like how many cells or how much cells that we have in replicative cycle, how much we have cells in this tumor that are actively or rapidly dividing cells. Because if the fraction of these cells is increased, this means that the sensitivity of the cancer to the chemotherapy is increased, and vice versa. We will discuss this in a minute and with each drug alone. So as we said, this influences in the susceptibility of the cancer to the chemotherapeutic agent. It is not like rapidly dividing cells are generally more sensitive to chemotherapy, while the slowly proliferating cells are less sensitive. In general, also non-dividing cells, which means the cells in the G0 phase here in the cell cycle. So here it is like, it is good to mention, like, here the cycles of the cell growth. Here mainly we have 5 phases or 4 phases if we are combining M phase with G1 phase, and it is called G0 phase, and then we have S phase and G2 phase. So this one is the when the cells is dividing, while this one is the cells like after dividing, like from the mitosis. After mitosis, we have what it is called a resting states. So here the cells are not dividing. After that, just here we have like synthesis of enzymes are needed for DNA synthesis. Then we have in the in S phase, then here we have replications, or the DNA starts replicates itself to prepare the cells for dividing again. Then in the G2 phase, we have synthesis of other cellular components other than or in addition to the DNA in order to put cells in the M phase, and in the M phase, it is the dividing phase, and here we have two daughter cells here again. Then we will start again the resting phase and starting to synthesize DNA, dividing DNA, and synthesis other components, and repeating the cycles again. So this leads to two major terms in our lectures, what it is called cell-specific or cell cycle-specific drugs and cell cycle non-specific drugs. Here we have many examples such as antimetabolites, bleomycin, etc. But these are effective for high growth fractions. When we have high growth fraction, like high numbers of actively dividing cells in the sensitive. So here it is important to use cell cycle specific drugs in order to treat this cancer. While when we have, let's say, low growth fractions, maybe we have to use cell cycle non-specific drugs when these drugs are working on the not only in the dividing cells, but even on the cells that are in the resting state. So here it is important to memorize these terms, cell specific and cell non-specific, and we will discuss this in a minute. But this doesn't mean like necessarily the cell cycle non-specific are not working on the dividing cells. Also, they are working on the dividing cells, but also are working on the non-dividing cells. So here we have, as we talked in the previous slide, cell cycle specificity of drugs. Both normal and tumor cells go through growth cycles. It depends like in the organs in the normal, like some organs such as the gastrointestinal tract, hair follicle, or the skin. These are actively dividing cells in the normal state, what I mean. But in the cancer, of course, everything is changing. Even organs that are not dividing, such as CNS, could get like rapidly growing cells. The number of the cells that are in various stages, as we saw in the previous slide, like S phase, G phase, or M phase, are different if we are comparing the neoplastic tissue with the normal tissue. So in the neoplastic tissue, maybe we will see more cells in the S phase when the cells are needing to dividing as much as faster they can. Then, and this leads to the chemotherapy are only effective on the as we said in the previous slide, like chemotherapeutic agents, if they are cell specific, they are only active against cells who are in the cell cycle or they are replicating in the cell cycles. While the other drugs that are cell cycle non-specific are acting on both on the cells are actively dividing and cells are not actively dividing. So these are non-specific. So they are not non-specific for the cell cycles. They are attacking cancer cells by attacking certain metabolites, as we will see in a minute. But as we said also on the previous slides, this doesn't mean necessarily that the cell cycle non-specific only works on the cells are not dividing, but also they are working on the dividing cells, unlike the cell specific, which are only attacks the cell or cells in the cell cycle. Then we have what it is called tumor growth rate. In general, tumor growth rate, like the speed of tumor growth, is so fast at the beginning of the cancer, but this rate starts to decrease with the time, and this happens due to an increasing or that the tumor becomes in a larger, let's say, in a larger state. So it needs more oxygen and nutrients, and the blood vessels that are supplying to the tumor are not enough to supply all the needed nutrients and oxygens, and this causes decrease in the growth rate due to the enlarging in the size of the tumor. So a tumor burden can be reduced by, as we said, by different ways, either by using surgery or radiation, or by using cell cycle non-specific, because here we have, let's say, a broader chemotherapeutic agents. After decreasing the tumor burden, like decreasing the burden of the tumor or the size of the tumor, here we can use or convert the treatment into cell cycle specific. Here we have another or a second activating phase in order to increase the size of the tumor again. So here it is important to use cell cycle specific, unlike in the first stage when the burden of the tumor or the growth rate of this tumor, when the size of the tumor in the first one, when the rate decreased due to an increase in the size of the tumor. Here it is important because here the activity of the cells or the dividing capacity of the cells decrease of the tumor. So it is important to recommend using cell cycle non-specific drugs. But after removing or decreasing this burden, here we have to change the treatment to cell cycle specific chemotherapy, because here the tumor starts to increase again in the size. Then we have what it is called local phenomenon. It is done as well, like destruction of cancer cells by chemotherapeutic agents follows first order kinetics. And this is very similar to what you learn from the lectures in the introduction of pharmacology, the first order removing a constant amount of the drug over certain period of times. Here also we are removing let's say similar or the same amount of the cancer cells over the same time intervals. And to describe this phenomenon, we are using local. And we have here an example just to explain this more. So let's say an example, like there is a diagnosis with leukemia, or there is a blood cancer here. And this is specific for the white B cells. In general, made when there is about like 10 to the power 9 of leukemia cells. So we have identification or diagnosis that the patient have tumor cells in the blood greater than 10 to the power 9. So here we choose a treatment, and this treatment causes like around 99.99% killing of the cancer cells. This means then we have only remaining around 0.001 of the cancer cells after treatment, because this treatment is killing like 99.99%. So the remaining cells is 0.001% of 10 to the power 9. This means that the remaining cells, or the amount of the cancer cells that remain after treatment, is around 10 to the power 4. This means that the number of the cancer cells is decreased by 5 log. So this means, so this is what it is called local, local, like how much cancer cells is reduced by the chemotherapy. And this patient, like in the same example, and this patients after killing around 5 log of the cancer cells, 10 to the power 5 of the cells were killed by the chemotherapy. The patient here becomes asymptomatic, and the patient's in a remission state. It is a very good state. So to compare this phenomenon with the antibacterial drugs, when we have also 5 log, like 100,000-fold reduction in the number of microorganisms. Here we are, our bodies use immune system to destroy or kill the remaining bacterial cells in our bodies. While we don't have a similar, even our immune system, if it is activated after chemotherapy, but doesn't have this capacity to remove all the remaining cells after using the chemotherapy. Sometimes, as we said in the beginning of this lecture, that there is a new direction in chemotherapy or in cancer treatment by using drugs that are activating the immune system. And here we have pharmacologic sanctuaries. Here we have certain parts in our bodies. It is called like sanctuary sites or sanctuary parts, such as the central nervous system, because we know there is a blood-brain barrier, and this barrier prevents many things from passing from the blood to the brain. And here we have a similar concept with the tumor. Tumor also have like a kind of a barrier. It's not just it's not similar to the blood-brain barrier, but it is like a barrier prevents not everything from entering to the cancer. It is a kind of protection of cancer from many things, chemotherapies or other unwanted products that could reach to the cancer and could kill cancer cells. So this is what is called pharmacological sanctuaries. It is important here, like if we have this situation, by using multiple strategies in order to avoid this in patients, such as using irradiation of the craniospinal axis, or by using, for example, intrathecal administration of the drugs, or sometimes there is a topical administration of the chemotherapeutic agents to the site of the cancer in order to get enough concentration of chemotherapy in the cancer. Then we have combinational therapy. It is very important to use combinational chemotherapy regimen. It is very beneficial, and I think maybe there is no one cancer now is treated by only one drug. It is very important to use multiple drugs to treat cancers. So, but how can we combine the different drugs to treat a certain kind of cancer? It is like recommended to use the drugs or cytotoxic agents with different toxicity, with different side effects. And also they have, it is better to have different molecular size and mechanism of action. So some of them, let's say anti-metabolic, the other are working on the or alkylating agents. Just as an example, just to show that we are combining drugs with different toxicity profiles or side effects profiles, and also they have different mechanism of actions. And our goals from this, in order to get these goals, like increase the efficacy of each drug, like combining drugs with different mechanisms, and increase the efficacy of each drug alone. And also there is no increase in the side effects or the toxicity, and these drugs in general very toxic drugs, so it is better to keep them in a combination that is not over activating the side effects profiles. Here we have some examples, like say myelosuppression, nephrotoxicity, cardiotoxicity. These are just as examples to the most common or most popular side effects that could occur with the combinational treatments. However, if we want to summarize the major advantages from using chemotherapies, we have 3 main points. Combinational therapy provides maximal cell killing, increase the efficacy of each alone. Maybe there is synergism, maybe there is just additive efficacy. So different, it depends on the combined treatments. It is also because we are using drugs with different mechanisms of action, it is gonna be a broader, is gonna to work on a broader range of cell lines in heterogeneous tumor population, especially if there is metastasis. Here we are expecting to deal with different kinds of cells and all of them in cancer state. So it is better to use drugs with different mechanism of action. And also there is another advantage: combinational therapy could prevent or delay the development of resistance to the chemotherapy. As we said, this is a very common problem that happens with the chemotherapies. Here, just to show an example for what we talked above, like many cancer treatment protocol have been developed and each applicable to a particular neoplastic state, but it is not like if we have, let's say, for example, if you have leukemia, so we have certain treatment protocols. If you have, let's say, cancer in the prostate, different protocols, cancer in the lung, different protocols. So there are many protocols are available, depends on the site of the cancer. For example, here we have an example. It is called RCHOP, as used for the treatment non-Hodgkin lymphoma. And this one is composed from rituximab, monoclonal antibody, cyclophosphamide, hydroxy, daunorubicin or doxorubicin, vincristine, vincristine, and prednisolone, steroidal anti-inflammatory drugs. This treatment is, let's say, is scheduled an intermittent way in order to give a time for our immune system to be activated, because we know like all of these, maybe all of these treatments are immune suppressant. So it is important to give a time after the treatment or the protocol for our immune system to be activated again in order to attack the remaining cancer cells, and also to prevent the risk of serious infection that could patients with cancer get. Then we have, as we said, a very common problem and a very serious problem with the chemotherapy is the resistance. Certain kinds of cancer, such as melanoma, this kind of cancer is inherent resistant to anti-cancer drugs. This is related to the genetics that are found in the melanoma. So there is no way to avoid this either by using radiation, surgery, or by using drugs. Maybe the cancer is sensitive. So this is a very hard situation. While what we can do more with the how to prevent cancer from getting resistance, and as we said, like one of our strategies by using combinational therapy. But this resistance happens due to the if we are treating the cancer with the suboptimal dose for a long time, this one leads to certain mutations or new mutations in the cancers, and these mutations, let's say, develop a new resistance in the cancer for the treatments, and the cancer becomes now resistant to the treatment. Even in the beginning, it was not, but now it is resistant. So this one of the ways that many cancers get the resistance, like using low doses for a long time, and it is done the reason for the using these low doses for a long time, just to put the patient in the remission state. So it is recommended, if the resistance developed, using short-term, intensive, intermittent therapy of combinational drugs in order to decrease the capacity of cancer to develop resistance. Also, as we said, combinational therapy is effective for a broader range, as we said, from the advantages. So it is important to use combinational therapy. Here it is important to mention, even if it is not in the lecture, cancer, it is known as a smart disease, brilliant disease. Like even if you are in the beginning, you are using certain drugs, after a while, these drugs become ineffective due to the resistance, and the cancer cells develop or activate new mechanisms in that new biological mechanisms inside the cells in order to develop this resistance. And even after changing this protocol to a new protocol, resistance happens again, and there is like a cycle of resistance. So it is important, if it is controlled or managed from the beginning, to use short-term intensive intermittent therapy. Also, we have another thing, and this picture here just to show this example, and then we have a multi-drug resistance, and as we said, this is an image or picture just to show the mechanism of this multi-drug resistance. And this is important to mention here in this lecture, because this kind of resistance is a multi-drug resistance. It's not just a resistance to a certain kind of, to a certain class of the chemotherapy, or just one drug, one cytotoxic drug. It is affecting multiple drugs at the same time. And this happens due to, as we said, like activation certain genes, and these genes then activate or codes for the transmembrane protein, and in this case P glycoprotein. And activation P glycoprotein increase the outflux of the drugs from the inside the cancer cells to the outside of the cancer cells. And of course, this process is ATP dependent. So it is through using ATP and activation of the P glycoprotein, the drugs, instead of concentrated inside the cells, becomes concentrated outside the cells. So here, this mechanism is not specific to a certain drugs. It is affecting multiple drugs, because most of these drugs are entering inside the cells by a similar way, by P glycoproteins or by other carriers. And this leads to what it is called cross resistance following a use, even structurally related drugs. Here we have an example, as similar to here in this figure, like if sometimes cells are getting resistance to the vinca alkaloid, actinomycin, anthracycline, colchicine, and vice versa. And this affecting, there is a common feature between these drugs, like all of them have a hydrophobic aromatic ring with a positive charge and a neutral pH. Maybe this is the common feature between these drugs, lead to the this multi-drug resistance. It could be possible. On the other hand, we have strategies that can be used in order to decrease the output of drugs from inside the cells, such as by using channel blockers. And here we have verapamil as an example for this. But due to the side effects that could be caused by verapamil, is not, let's say, there are limitations for using verapamil. There are other agents now are recommended to be used as channel blockers or pump blockers in order to prevent drugs from pumped outside the cells. Then we have to talk about toxicities or the side effects, since it is also a very important problem with these drugs. As we said, like therapies or chemotherapies are their goals in to kill all the cells in the dividing cycles, cells that are actively or rapidly growing cells. Unfortunately, as we said also in the beginning, there are no very specific chemotherapies, because they are affecting both normal or normal and abnormal cells, which are actively dividing cells. And we have common cells that are normal, but they are always, for a long time, they are actively dividing cells, such as cells in the buccal mucosa, bone marrow, gastrointestinal tract, and hair follicles. So we have common side effects from using chemotherapy, such as we see Maybe all patients, they lose their hair. All of patients, they have gastrointestinal side effects, severe vomiting, ulceration, or others. Most of patients will get bone marrow suppression and decrease their white PCs, RBCs, platelets, and as we said, also increase the side effects such as mucosal inflammation. Um, most commonly used chemotherapeutic agents have a narrow therapeutic index, a small difference between the therapeutic dose and the toxic dose. So patients, even if there is a small increase in the dose, patients are suffering from vomiting, stomatitis, bone marrow suppression, as we said, because the chemotherapeutic agents are not differentiating between normal and toxic or the cancer cells. Alopecia to a different, to a varying event extents, and these are very common side effects and also very frequent side effects maybe all patients will get after using chemotherapies. So here it is just to show, let's say, the different capacities of different chemotherapeutic agents in inducing myelosuppression. So we will see like here, like cyclophosphamide and tolvenplastin, these are very toxic to the bone marrow, while in the moderate state we have carboplatin, 5-FU, they are in the moderate state, while to lowest extent to induce myelosuppression we have bleomycin MTX. So also we have certain strategies in order to control these side effects, such as for the vomiting using antiemetic agents, and there are very powerful agents for this one. For the myelosuppression, it is important, like maybe we can keep the bone marrow, like extract bone marrow from the patients and keep them in a certain banks, then reuse them after the ending of the chemotherapeutic agents in order to maintain the immune system, its capacity to defend against certain infections. Also, for the gallbladder or bladder toxicity, you have certain drugs that could induce this, such as cyclophosphamide. We have cardiotoxicity could be induced by doxorubicin. Pulmonary fibrosis maybe could be induced by bleomycin, and all of them maybe can be controlled by changing the dose of the drug or by combine other drugs that are not causing these side effects. So maybe we can use certain strategies in order to minimize the effects of the adverse effect that could be caused by chemotherapies. Unfortunately, some of these or side effects that induced by chemotherapies can be they are transient, such as alopecia, but some of them are irreversible, such as cardiac, pulmonary, and bladder toxicities. So it is important to find, let's say, solutions from the beginning when we are starting using protocols to treat cancer. Then we have, as we said in the previous slide, then we have how to deal with this side effects. We mentioned in the previous slide, like we can keep the bone marrow in certain banks and reimplant them after discontinuation chemotherapies. Also, we can use cytoprotectant drugs, let's say for gastrointestinal drugs, or maybe by using local administration of chemotherapy, but this is not attainable only if the cancer can be reached by local administration of the chemotherapy. As we said, bone marrow suppression may be controlled by other way. Here in the case of methotrexate, because methotrexate affects on the folic acid metabolism, we can use, let's say, folinic acid or leucovorin as an outer source for folic acid in order to decrease or minimize the side effect of methotrexate. Also can be used, let's say, a granulocyte colon stimulating factors if the neutropenia happens in patients with cancer due to the chemotherapy. So these are just certain examples. These are common examples, or these are common strategies are now used to minimize the side effects. But there are other ways. It is not important to know all the ways, but just to understand how can we minimize or reduce the extent of side effects. It is done also. All treatments, or maybe the majority of chemotherapies are or induce mutagenesis and neoplasms. So these are anti-tumor, but they are causing tumor as well. So they are causing tumor. But and this could happen, like as we see here, like could happen in around even after 10 years after discontinuation of chemotherapy. However, unfortunately, the tumors are induced by anti-tumor agents are curative by anti-tumor as well. So maybe this advantage or this feature with the chemotherapy is used if the tumor is developed due to using previous chemotherapy. Let's start with the first class of chemotherapeutic agents, the antimetabolites. Antimetabolites are structurally related to normal compounds that are existing inside the cells. So this class or drugs in this class interfere with the availability of normal purine and pyrimidines, and as none, these ones are building units of the DNA, so they are preventing DNA and RNA synthesis by reducing the availability of these building units. And all of them are cell cycle specific, and they target cells in the S phase. This table, it is up to you. Like if you want to memorize everything from here, it is up to you, but we will discuss all these. We will mention the main characteristics such as the mechanism of action, side effects, and other features from the pharmacokinetics with each drug alone. But if you want to memorize everything from the table, is up to you. So here in the beginning, we have methotrexate, bimetrexate, and pralatrexate. We will see on the with these agents are targeting, all of them are targeting folic acid. So folic acid, it is very important vitamin that are used during the cell cycle or cell replications. Because folic acid, if it is not available, there is no availability for important building units, as we said in the previous slides, such as adenine, guanine, thymidine, methionine, serine. These are very important building units to form DNA and RNA. And here we have three major agents, as we said: methotrexate, MTX, bimetrexate, and pralatrexate. So from this figure, or here if you want to, it is up to you. It is just the same thing. So MTX is structurally related to folic acid, and it acts as antagonist of this vitamin by inhibiting dihydrofolate reductase. So after transferring this drug from outside the cells, then inside the cells, methotrexate has a similar or a structural similarity to the folate. So it inhibits dihydrofolate reductase in this step to be converted to, and in this step to be converted finally to tetrahydrofolate. So it prevents the formation of tetrahydrofolate through targeting dihydrofolate reductase in these two steps. In order to overcome or reduce the action of methotrexates, it is recommended to use 1,000-fold excess of natural substance dihydrofolate, and this one in order to overcome the effect of methotrexate, or using leucovorin. And leucovorin, here, the molecule right here, it is bypassing all these steps. So the building units of DNA and RNA is synthesized directly from this step without passing all these steps. So there are two ways in order to overcome the toxicity or the side effects of the methotrexate. However, the most commonly used one is by using this folinic acid or leucovorin in this step right here. So the mechanism of action inhibiting the formation of tetrahydrofolate through the inhibition dihydrofolate reductase. This for the MTX. Pemetrexate also has a similar mechanism to the methotrexate, but it also inhibits other enzymes in addition to dihydrofolate reductase. Also inhibits thymidylate synthase and other enzymes that are important for the folate and DNA synthesis, folate metabolism and DNA synthesis. While pranatrexate, this one is very similar to methotrexate. Therapeutic uses, methotrexate is prescribed for many kinds and different kinds of cancers, such as breast cancer, bladder cancer, lymphocytic leukemia, and also is used now in low doses, not like cancer doses, for other inflammatory diseases such as rheumatoid arthritis, Crohn's disease. But it is important to monitor the side effects of the methotrexate, especially the side effects on the blood. While we have pemetrexate, and this one is used mostly for non-small cell lung cancer, and pralatrexate is used for relapsed or refractory T cells lymphoma. With the pharmacokinetics, methotrexate is available for different routes of administrations, parenteral administration, even intrathecal administrations is also available in oral as oral tablets, but I think for cancer is mostly used by IM or intravenous administration. As we said, it is available as well as intrathecal because it doesn't pass the blood-brain barrier sanctuary of the CNS. And high concentration of the drug can be found in different organs such as liver, kidneys, and also it reaches to the skin. There is an important feature with the methotrexate. It is metabolized into, let's say, more toxic metabolite. It is called 7-hydroxymethotrexate. And this one is less soluble than methotrexate, so that it is concentrated in the gallbladder and causing crystalluria. So it is important in order to minimize or control this side effect. It is important to alkaline the urine and advise patients to use as much as they can of water or hydration in order to increase the excretion of the parent drug methotrexate with its metabolite. With the similar effect, there are common side effects, as we said, in the side effects with the chemotherapy, such as gastrointestinal side effects, myelosuppression, hair follicle losing, and these can be seen in this figure or in this table at the beginning of this class. There are certain strategies can be used in order to reduce the side effects, especially with the pemetrexate and pralatrexate, by using folinic acid or folic acid with vitamin B12. Also, there are other ways. It is, I think it is specific only for pemetrexate, by using corticosteroids in order to reduce the cutaneous hypersensitivity reaction. Until here, we stop here with the 6-mercaptopurine, and we will start from this point in the next lecture. Thank you very much, and of course, if you have any questions, just let me know in the comments.